Okay, I will just go ahead and kick us off. Hi, everyone. My name is Adam Goss with Mental Health Colorado. I'm just filling in for Vincent this morning. Thank you all for taking the time out of your Thursday this afternoon to learn a little bit about some of the efforts across our state to disentangle mental health and criminal justice. So today we will be highlighting the Harm Reduction Action Center here in Denver, and we'll have a presentation from the Executive Director, Lisa Raville. So thank you so much for joining us this morning, Lisa. And with that, I'll just give you the floor.
Thank you so much for having me today. I really appreciate it. This old gal's getting older, so I wanted to just keep on task with the PowerPoint. It sounds like we'll be doing questions in 15 minutes. So I speak quickly. It's kind of my thing. So let's get going. Harm Reduction Action Center is Colorado's largest public health agency that works specifically with people who inject drugs and people who smoke drugs. And when we talk about people who are smoking drugs, we're talking about crack, meth, and now fentanyl. We are in the worst overdose crisis we've ever been in. This is a fentanyl overdose crisis, and it's a polydrug overdose crisis. You're seeing fentanyl and hearing about it more and more. We've had it in Colorado since about 2018. It was on the West Coast as of 2014. Where we're also seeing it too is that heroin is more difficult to come by now due to climate change and lack of poppy cultivation. And so it's much easier for folks to make fentanyl as a synthetic opioid in labs, which is why there's this drug shift. So for years and years and years, you just had the same old drugs doing the same old things. Now, much like when there was prohibition in the 1920s, they weren't brewing beer, right? They were using hard alcohol because it was easier and cheaper to make. So that's kind of like where we're at with all that too. There's a lot of nuances. Harm reduction reduces the harms associated with drug use. We use lots of forms every day in every way: sand in a playground, helmets when riding a bicycle, right? And if stigma, shame, and incarceration worked with drug use, we'd have wrapped this puppy up years and years and years ago. All that's done is drive use underground, where people have gotten preventable chronic diseases such as HIV, hepatitis C, and died of overdose. So we're doing something different. We also know that relapse can be a part of recovery for so many folks, right? And harm reduction, quite frankly, means we're rooting for you. How can we support you for a healthier and safer you today? There is something positive that folks can do today. Harm reduction is no place for ego. It's a place to forget what you think you know and set aside your opinion so that when you meet people where they're at, you can take the time to ask them where they want to go. The war on drug users has been incredibly racist in classes since forever, but especially since 1971, when the war on drug users was declared. That was the time that the DEA was established. We know that crack was first developed and introduced in the 80s. Then we had the Anti-Drug Abuse Act of 1986, making mandatory minimum penalties for drug offenses. Then we had the 1995 crime bill, which contributed and contributes to mass incarceration. One of the concerns that we are seeing is that there's a lot of talk, especially when we're talking about fentanyl and criminalizing people who use fentanyl, is the doubling down on incarceration. And again, incarceration has never worked for drug use. We could talk all day about that, but I only have 15 minutes. There's a common misconception that people who inject don't care about their health. They actually do. Anytime you break your skin, you're at risk of infection. One swipe of an alcohol pad will keep folks out of the emergency department for costly skin tissue infections. We have black tar heroin in Colorado, which is difficult to snort and expensive to smoke. So you almost have to exclusively inject it. So the average heroin injector injects 3 to 5 times a day. The average meth injector once or twice a day. The average cocaine injector 12 to 15 times a day. I want to make sure that folks have new sterile equipment every single time to prevent and eliminate the transmission of HIV and hepatitis C. Why does someone inject? Nobody just wakes up and says, today is the day I'm going to start injecting. It's going to be magical, right? Vincent and I are hanging out sharing a bag of cocaine. He snorts his half up. I only need a little bit to inject with. He's going to look at me and he's going to say that looks like a bigger, better high, more economical, and to show him how. So we talk about not modeling in front of non-injectors so you don't even get asked. And as you know, opioid users never want to be in withdrawal. It's physically painful. The flu times 1,000. So what they are appreciating now about fentanyl with being sold in the pill form is that they're smoking it, meaning they're no longer having to inject, right? So it's reducing skin tissue infections, but there's also a street rumor that you can't overdose on smoking fentanyl. You absolutely can. Fun facts about syringe access programs. It's currently happening in 35 states and 60 countries. We were not being revolutionary, I can assure you. And we have about 15 of us in the state. That's probably going to be about it. There's not a lot of glory in starting one, I can assure you. So Harm Reduction Action Center has been an agency for almost 20 years. We've only had the ability to exchange syringes for the last 10. So it improves public safety, it protects law enforcement, reduces needle stick injuries, it promotes proper syringe disposal, it engages folks for a healthier and safer than today, offering resources and referrals. So in the last 10 years, we've had over 12,000 folks sign up with us. No one's mandated to be here, thankfully. These are folks being proactive about their health. Those syringe access episodes are every single time we're engaging with folks, creating a relationship where they can dispose properly of used syringes, access to sterile syringes, and offered referrals. Do you want to talk to staff today about Medicaid enrollment, mental health, substance use treatment, naloxone, health education classes, fentanyl testing strips, PrEP? Over 100,000 times they said yes, right? But what are my trickiest referrals in town? Mental health and substance use treatment. We can talk about that too. We also have access to naloxone or Narcan. It's safe and highly effective. Paramedics and emergency departments have been using it for over 40 years, which is really great if overdoses happen around paramedics or emergency departments. So it needs to be in the hands of people who use drugs first and foremost, because they're the true first responders in the midst of this overdose crisis. And then third parties, people around people at risk of an opioid overdose, mothers, homeless service providers, me, you, anybody in the state can carry it. Drugs injected most in the past 30 days. We're about 50-50 at heroin and meth injected most. We do see among our folks that are unhoused, they inject meth in the winter so they can, especially on a snowy night, so they can walk around the city and not lay down and freeze to death. So for a lot of our folks using meth as a survival method, for example, this morning we had a lot of folks come in who needed clean socks. They've been walking around all night with a blanket around them and in gym shoes. We also have safer smoking kits, right? We want to engage with folks for healthier and safer them with the tools they need to create a relationship. Smoking is risk reduction over injecting, and so making sure that folks have access. So we have race and ethnicity at intake. We also do mobile street outreach in high drug traffic areas. So that's important that we go around, and also encampments. 72% of our folks identify as male. 0.5% identify as trans. There's a lot of underground hormones and steroids going back and forth. You need a larger gauge syringe, which is really hard to come by, like a 23 or a 21. 90% of folks have never been to a syringe access program before. In some states, law enforcement sits out front and profiles. Thankfully, they don't do that here. I currently get more referrals to my program from the Denver Police Department than I do from any of the healthcare providers. 19% of our folks are Hep C positive upon intake, 3% are HIV positive. For the folks that don't know their status, do you want to test today? After reviewing all the research to date, the senior scientists at the Department of Health and Human Services and I have unanimously agreed that there is conclusive scientific evidence that syringe exchange programs as part of a comprehensive HIV prevention strategy are an effective public health intervention that reduces the transmission of HIV and does not encourage the use of illegal drugs. Now, if we were all in the same room, I'd have you shout out what year you think Dr. Satcher said this. April 1998, welcome to the late 90s. And actually we've had syringe access programs in the United States since 1987. The first one was in Tacoma, Washington. All drugs need to be made as blood-like as possible to inject. When folks don't have access to sterile water, doesn't mean they don't inject. It means use toilet intake water, river water, or saliva. If I'm Hep C positive and I have my injecting water and I let Vincent use that, right, and he has heroin, but no water, that's how he can get hepatitis C. Hepatitis C lives in injecting water for 62 days. So folks know not to share the syringes, but the clickers, the cottons, the tourniquets, the water oftentimes is the issue. This is the magnification of a needle before use, after one use, and after 6 uses, it starts to curve and shred. When you don't have a syringe access program in your community, it doesn't mean that folks aren't injecting, it means they're using that one. In all 35 states and 60 countries, syringe access programs look a little different. One of the issues that we have is no good media representation of a syringe exchange program. People assume it's a dark and dingy house, right? There's a lot of life that happens in here. So we lure folks in for tours when participants aren't here to see what we are and what we aren't. Access to service providers, mail and phone. We've passed 7 pieces of statewide legislation in the last 12 years, 4 to reduce the harms associated with overdose, 3 to reduce the harms associated with syringe criminalization. We also have passed 3 Denver City policy changes. We believe the street should influence the policies at the state capitol and with Denver City Council. We have mobile street outreach in high drug traffic areas, health education classes, right? It's difficult to protect yourselves and others if you don't know how you acquire HIV, Hep C, things like that. We have fentanyl testing strips where folks can test their drugs and see if fentanyl or fentanyl analogs are present before they use. We've had that since 2018. Here's the thing, in the next 6 months, I probably won't give out the strips anymore because everything's going to have fentanyl in it. That's what the drug supply and the drug market has brought us. So buckle up, buttercups. referrals, HIV Hep C testing. Okay, and you're like, all that, how is she as a neighbor? We're award winning. Thank you so much for asking. My folks are invested in the health and safety of the community in which we serve because we're that one safe space in the entire world. Folks can talk realistically about their drug use. We also do litter cleanups led by participants in the area. It's one thing to say you're going to be a great neighbor. You got to show people you're a great neighbor. And there's a lot of litter bugs in town. I told you I speak quickly. The question of enabling, let's just talk about it. I got into harm reduction to enable people who use drugs to protect themselves and their communities from HIV, hepatitis C, and overdose, to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity, to ask for help and to help others in turn, to find drug treatment and healthcare, to reconnect with their families, to rebuild their lives, and to take personal responsibility for their health and their futures. If that makes me an enabler, I'm proud to claim that term. We went a long time not doing anything. We lost a lot of good people, right? Dead drug users do not have the opportunity for recovery. And when people are alive, there's hope. Okay, we're transitioning. We are in the worst overdose crisis we've ever been in. It's a fentanyl overdose crisis, and it's a polydrug overdose crisis, meaning there's usually 3 or more drugs on board. I know this is a hard map to look at, or a hard slide to look at, but I like it because it doesn't just talk about the overdose deaths from 2000. This starts in 1980. We lost a lot of good people over a long time, right? And it doesn't have to be like this. In 2020, we lost 93,000 folks in the United States. We lost over 1,800, well, actually 1,400 in the state of Colorado. And then we had 370 in 2020, just in the city and county of Denver. We also know preliminary numbers for 2021. We're at 454 just for the city and county of Denver. So 2019, 2020, and 2021, we've lost over 1,000 folks to drug-related deaths just in the city and county of Denver. We're not even plateauing. And again, it does not have to be like this. There's 4 main reasons why people overdose. The first is the quality of the drug. The supply is unpredictable. The second main reason is any period of abstinence, coming out of jail, prison, treatment, living a life of recovery. Folks coming out of incarceration are 129 times more likely to overdose post-incarceration in those first 2 weeks than the general population. The third main reason is mixing, so alcohol and fentanyl, benzodiazepines and opioids. And the fourth main reason is simply using alone, by the very fact that no one's there to witness, recognize, or respond. So we do have access to naloxone or Narcan. It's safe and highly effective. We talked about that earlier, right? Anybody in the United States can carry it. Anybody in the state of Colorado can carry it. People who use drugs, people around people at risk of an opioid overdose. If you walk on earth, you should be carrying it. It's an opioid antagonist. You can't get high from it. The only thing it can do is knock the opioid off the receptor and hold for 30 to 90 minutes while you rescue breathe for someone and call 911. That's it. There's 4 main kinds. This goes up one nostril and sprays. We need to make sure to have it in the hands of folks. This is our overdose memorial wall. It's actually grown. We've had to add a whole bunch of photos on that right wall too. This is our why. Right? And again, it doesn't have to be so. Opioid overdoses are preventable. There's a lot of response myth out there. How many times have you watched a movie and they've thrown somebody who's overdosing in the shower, right? The fentanyl testing strips to test their drugs and see if fentanyl or fentanyl analogs are present. Anybody in the state of Colorado can carry naloxone. There's over 470 pharmacies today in the state of Colorado you can walk into and get access to naloxone virtually over the counter. Most major insurances cover it. You just have to pay your copay. 204 law enforcement departments in the state carry Narcan. DPD was first. Colorado Springs PD was second. And there's 6 county jails that train heroin users in jail how to recognize and respond to an overdose and put that naloxone in their property for upon release, because they know about that 129 times more likely to overdose post-incarceration. That's Arapahoe, Boulder, Denver, Douglas, Larimer, and Jefferson County jails. Anybody with a JBBS contract in the state has money in that line item. 7 pieces of statewide legislation we've passed. We have 2 911 Good Samaritan laws. Vincent and I are hanging out doing drugs. He overdoses, and in good faith, I call 911 and stay with him. We don't get new drug charges. He goes to the hospital. I go on my merry way incentivized. What I'm concerned about currently is there are rumors at the Capitol that they're interested in doing a drug-induced homicide bill, essentially making every overdose death a murder investigation. That's going to actually increase overdose deaths because folks will definitely not call 911. This is the Safer Syringe Disposal Initiative. They're about 4 feet high. If you've ever been in New York City, you've bumped into them all over the place. We do have 6 of these in Denver to allow for proper disposal. People living in chaotic drug use tend to be more successful at making positive changes in their lives if they first have their most basic needs met, like food and shelter, access to healthcare, meaningful connection, and being treated with dignity, regardless of whether or not they continue to use drugs, and not contingent on if the difficult circumstances in their lives have changed. So I'm just going to take about 2 more minutes to close out, because that's where we're currently at. Right now, we can do everything to prevent, eliminate the transmission of HIV and hepatitis C, resources, referrals, naloxone, fentanyl testing strips, but it's not legal for them to use on my property. Use and possession on the property can get the property seized. So they go a few blocks away to an alley or a business bathroom, and they inject or smoke there, often alone. Not only are they smoking or injecting there, they're overdosing, and they're dying of overdoses in public places. And it used to be cops coming up on people overdosing, and everybody was fine with that. Now it's 17-year-old baristas who are being re-triggered every day because they don't want to clean the bathroom before they go home because they've come up on somebody overdosing. It's currently happening in 12 countries and over 150 sites. The drugs are pre-obtained, meaning they're not bought or sold on site. People inject themselves. Reduces the acquisition of HIV and hepatitis C. It reduces skin tissue infections. These are the major players here, right? I want to be very clear that the #1 substance use treatment admission requirement in Colorado is you have to be alive. The bottom 3, it does not increase community drug use. It does not increase initiation into drug use. It does not increase drug-related crime. People are invested in the health and safety of the community in which we serve. Whether or not you support it, we'll always have use sites. I want mine supervised and sterile. It's been incredibly business friendly, as you can imagine. I have a business coalition. I've got docs. We've got law enforcement associations, neutral. I've got people who work with people who are service providers. We've got religious supporters. It's pro-life. We've got treatment and recovery. They love it. I can't get them in if they're not alive. And this is me, your local harm reduction freak. Any questions, issues, concerns?
Thanks so much, Lisa. Yeah, if anyone has any questions, please feel free to type in the chat or just come off mute and ask. Just off the top of my head, Lisa, I'm curious about how many people are you interacting with on a daily basis?
Sure. So we see anywhere between 60 and 125 people a morning. And we definitely have seen the drug shift from injecting to fentanyl over the last couple of years in particular, especially, so fentanyl is kind of twofold. One is we're finding it in heroin, meth, and cocaine. And then 2, we're finding it in those blue pills. My folks, again, we talked about, are smoking those blue pills. And, because there's a lot of hierarchy. Drinkers think they're better than everybody, right? Smokers think they're better than snorters. Everybody thinks they're better than injectors. So there's kind of a lot of those nuances that are happening too. Other questions?
Looks like we got one.
Great.
Okay, how do you or did you sell this program to law enforcement?
Oh, they're smitten kitten for harm reduction. They just really won't say it publicly. So I'm assuming you're talking about syringe access. You might be talking about overdose prevention sites too. I'll talk about it kind of twofold. So I just started luring in law enforcement to tour to see what we do and what we don't do. As another tool in the toolkit. They know incarceration doesn't work. They know they can't arrest their way out of drug use, or they would have already done it. So they've really shifted. So it's been a lot of education. Where we've really found their support is they're very concerned about getting stuck by a needle. So when we've passed 2 pieces of statewide legislation, it not only promotes proper disposal, I need the used syringes coming across town, and we are running about an 87% disposal rate, which is one of the highest in the nation, but also it reduces needle stick injuries to law enforcement. So we do that technical assistance for bureaucratic institutions in which our folks intersect with daily, because I want better relationships out there with people who inject and law enforcement. Again, they will refer folks over here. The tours, the reduction of needle stick injuries, that's been great. Where I've gotten them on overdose prevention sites is neutral, which feels like a win, right? So they're like, let's see what that looks like. Great, as long as they're not opposing it. But we are in the worst overdose crisis we've ever been in. Colorado will absolutely get an overdose prevention site one of these days. I just don't know how many more Coloradans have to die of a preventable overdose for us to be able to do something different. Other questions?
Go ahead, Sarah.
Oh, sorry. Sorry, and I apologize. I was a couple of minutes late, so you might have said this. What is the best way for people to connect with you? How do they get access to your program?
People who use drugs or the larger community?
Use drugs.
Okay, yeah. Well, peer-to-peer. And I'm glad you brought that up. So we get primarily to peer-to-peer referral, and people because 90% of folks have never been to a syringe access program before, they think either the cops sit out front and profile, and like I said, they do that in other states, or they think we're the cops, because why would we want to lure them in and be nice to them if we didn't want to get them, right? So they usually, like marketing, have to hear about us about 7 times. Their friend finally has to drag them in, and their friend's like, hey, you need to know this guy, this is a new guy. And we're like, hey, new guy, let's do this. So we do have a one-time HIPAA confidential enrollment that they do the first time. It takes about 10 minutes. They don't need an ID. They know who they are. Then they also get the rules of our space in the neighborhood, and then how to interact with law enforcement to carry sterile and use syringes in the state. Then they get syringes. They're offered, Narcan, fentanyl testing strips, snacks, and a coffee or cocoa for the road. Works out pretty well.
So just a follow-up question. I'm a part of that bureaucratic machine. And I know that part of what happens is that, like, once my machine makes a referral to a program like yours, it's almost like the stain of me gets on you.
Yeah.
I'm wondering if you have any thoughts about, like, is there a different way to do that? Or have you seen a successful way to make that sort of connection or referral without making so that it's clear that you are not me?
Totally. And that we're not connected. Like, one
Right.
of the biggest questions that I get all the time is, they're like, are you connected to parole? It's like, oh, heck no, nobody would be here. So, a lot of times what we find, and, your referral definitely looks different than like a healthcare provider too, right? But what's really nice about your referral is, like, if you suspect it or you really think it, I'm all breezy, cool mom. That's kind of how I go at things. I think I am. I'm getting older, so it's hard to know if that's really the case. But sometimes it's like, hey, I'm really nervous about, I don't know if you know much about this overdose crisis, but like, hey, there's a place that gives out free Narcan that works with people who use drugs. This lady presented, she didn't seem terrible. I don't know, just real breezy, because they've heard about us, it's all HIPAA, it's all HIPAA confidential. They're not connected to anybody, and then that's it. Much like, when we talk about treatment too, we don't bring it up unless they bring it up with us, because they know about treatment, right? But they want, like, once they want to get into the specifics. So for you, it's really just a breezy, like, hey, we had this presentation. Like, I just want to make sure people aren't dying of overdoses. Like, you should go get some free Narcan. That they sound pretty cool, or however, So just like, and it's like, what I like about harm reduction too, is just like, we're just planting a seed, just like breezy breeze. Cause that's not the first time they've heard about us. We do have, gosh, I'd say like maybe like 5% of referrals are from other service providers in the community. But you're right, because I can't be a part of HMIS, the Homeless Management Information System, because I can't brand my folks across town as someone who uses drugs if they're with another service provider or other systems that they have to be abstinent to do so. So there's oftentimes a lot of concern about that. One of the things that people should know too is I definitely don't need their name. But what I do need are their legal initials, year of birth, and gender they identify, because they're going to get an exemption card, and that's how they're going to interact with law enforcement. A lot of people like having that exemption card because they're, you don't want to get picked up for syringes. That'd be ridiculous. And so like that's oftentimes a lure, especially for meth users, is they like that. Plus we have the pipes now. That's been very, people are very pumped about that. So in the last year and a half, we've given out probably about 40,000 pipes. So that's been great. Sonia, did you have a question?
I did. And I'm sorry, Sarah, that I interrupted you. You were on a different screen, so I didn't see you. For the people who do say they want to engage in SUD treatment, is that easy for you to get them there, or do you find a lot of that's what I'm trying to figure out. Like, yes. What's the capacity and actually
Sonia, you had me at hello. You'd think as the largest syringe access program in the state of Colorado, I'd have a really good gateway. I don't. Inpatient's a story of hope. Almost no one goes to inpatient anymore. We have social detox, but we don't have medical detox, which is tricky. We have almost virtually nothing for stimulant users, right? What we have found for our stimulant users that work is housing, right? That's substance use treatment. You don't have to use as chaotically walking around the winter if you have a safe place to be. They've done a much better job with medication assisted treatment for opioid use. We do want to see that for stimulant use too. It's been much better to get folks into MAT for opioid use. The lack of ID has always been a barrier. And so we really do, kind of do a lot of the baby steps with the ID. But we're in a little bit of pickle now because Suboxone, which you may be familiar with, which is medication assisted treatment, is difficult to induct with folks that use fentanyl. And it puts them in precipitated withdrawal. So now we have to do more education to healthcare providers about how exactly they need to be inducting. But like when one of the tools in our toolkit that isn't really working, that's going to be a problem too. So while we are a gateway and we do, we get a lot of people that ask about treatment and we sit down and we're going to make a plan about it for sure. It's much easier for us if they're an opioid user than a stimulant user to get them in. But again, inpatient continues to be a story of hope. And virtually nobody goes to inpatient anymore, unfortunately. And there's 28 days isn't even evidence-based. That's just what some of the insurances wanted to pay for it too. So, and then being discharged unhoused with all the crisis management that happens on the street too. And any period of abstinence puts people at higher risk of overdose. So we do have a lot of issues. So we are besties with treatment. It's just, I want to hold somebody's hand, walk two blocks down and say, Bill, this is Sarah, Sarah, this is Bill, fly, birdie, fly. And we're still not there. Although the ARPA funding, that one-time flash funding that's coming into the state is supposed to do some great things. And I know Vincent was a co-chair on that. Other questions? Do you have any thoughts on how to get drug users out of the criminal justice system? Jason, you had me at hello. I feel like in the last few years in Colorado, there's been a lot of movement of getting people who use drugs, and especially with possession, out of the criminal justice system. Where we've had an issue is the medical system isn't like, come nestle in my bosom, right? They're all like, I don't know. So you've got public health and harm reduction kind of in that little spot. And so once, and I'm sure you've been reading a lot and watching a lot on TV, now that they're talking about fentanyl, what they're wanting to do is double down on their worst idea again and incarcerate folks and go backwards from where we were trying to go. So really, this is the overdose. I think where we can all agree is the overdose crisis is wild. Where we believe it's a public health emergency that demands a public health approach. And we have not seen incarceration work for people who use drugs. So, we need to make more opportunities like the crisis management centers, which are great, like wet shelters, places they can be. I mean, a lot of times there's no place for people to be, which is, Union Station is an injection site. It's just not supervised. Of course it is, because Civic Center was an injection site that just wasn't supervised. And they'll push them on to the next injection site that's just not supervised. And I don't think everybody's going to live a life of recovery. I think we should be really clear about that too. And so how can we support folks for healthier and safer them today? And so we're getting to a better place of having those conversations with law enforcement and the criminal justice system. They've done a much better job, especially with the Narcan and especially medication assisted treatment in jails. That has been very helpful because a lot of folks were detoxed very quickly, if they were on methadone and outside of Denver, which puts people at higher risk of overdose, but really getting factual health information. But I think where we really still struggle is we've never had a good conversation about drug use in the United States ever. We've always thought incarceration was going to work. We've seen that definitely didn't work. We had DARE, we had Just Say No. So people's tummies hurt and they don't really know how it works. You'll notice I didn't say addiction once. I talk about chaotic and non-chaotic, problematic and non-problematic, because I don't know necessarily that the healthcare profession understands addiction either. So, part of having these conversations and part of, me being on the tour and answering stuff is we want to talk about it. In a magical world, there'd be no drugs, but we live here and it's very pragmatic. And I think we've done a real disservice to people in the United States. And it's no wonder why they incarcerate people for drug use when people really don't understand drug use in general. I know that wasn't helpful, Jason, but you had me at hello. Any other questions, issues, concerns?
I have one more question.
Yep.
Because I'm in Austin, Texas, and we had, and I was actually writing you, but I want to introduce you to someone who just moved to Denver from here, who was doing a lot of stuff. But it's gotten to the point where the best treatment we have, and it's been this secret that people didn't even know about, was in the jail, to the point where
Right.
people are asking their attorneys, do not get me out, I want to finish the program. So is Denver doing that as well? But that's just so unfortunate. Like, that's just the wrong way to go.
Well, Colorado has gotten a little bit over the last few years about jails in particular with Suboxone access, and continuing on their methadone. It's not the greatest, but the problem that we've had is there's a lot of folks that work in the criminal justice system that's really sold that treatment to law enforcement. So law enforcement often gets super pumped if they're arresting folks in there, because they're like, they're going to get treatment and everything's going to be great. And you're just like, well, they shouldn't have to now have caught a felony or or that like we need a better opportunity for that too. And then Vivitrol was really their lobbyists went straight to Department of Corrections. That's naltrexone, which is the one shot for 30 days stuff. I mean, their lobbyists really lobbied hard for Department of Corrections. Department of Corrections were like, okay, and giving the shot before people came out. But then there was no continuation, which puts people at higher risk of overdosing on day 29 and day 30. So really trying to have that support. What we're mildly seeing too here in Denver is there is a lot of secret support and meetings that I'm definitely not getting invited to, where it sounds like law enforcement and the mayor's office are trying to do mandatory treatment, guising it as something else, like they don't think I see them. I see them. And so I'm concerned about that too, because we haven't seen mandatory treatment work, and we don't even have the treatment access for people that actually want it. We still have the 90% gap, much like the rest of the United States. But Austin's got some really great you've got a really great harm reduction coalition that's come out and doing some really great hiring that I've had the opportunity to engage with a little bit. So yeah, I'm really pumped for you in Austin. Denver, don't worry, we're still here too, but pumped for Austin.
All right, any final questions that anyone would like to ask for Lisa here?
Don't hesitate to reach out if you don't want to do your question in front of everybody. But I think I put my email in the chat. Questions, issues, concerns. Did it feel weird? Did it feel counterintuitive? Of course it did. Not everybody's a harm reductionist. Let me send you stuff, right? We're evidence-based public health.
So Allie, we will be posting all of our reports and updates meetings on our website at mentalhealthcolorado.org. So this will be available for you to review if you didn't catch everything throughout the presentation. No worries. Thank you so much, Lisa. It's been incredibly informative, and the work that you do is just so important within our city. So it's thank you so much again for presenting for us today. And we will be continuing our series in exactly 1 month with a presentation from Michelle Muthing, who I believe is on with the Aspen Hope Center. And I just wanted to do a quick plug for us at Mental Health Colorado. We're actually hosting our Legislative Education and Advocacy Day tomorrow at noon. If you're again available around lunchtime, I'll go ahead and drop the link for that in the chat here quickly. But if you just go to our website at mentalhealthcolorado.org, you'll be able to find information for that as well. So I'll wrap up here. Thank you again to everyone. Thank you especially to Lisa for presenting and giving us information about harm. I'm completely blanking on it. Harm Reduction Action Center in Denver. And with that, I'm going to completely close out and thank you again for everyone who participated with us today. Take care, everyone.